Good evening, everyone. We will be kicking off in 1 minute time. Thank you all for everyone for registering and sending your questions through. I'm looking forward to getting some interaction with Chris on that.
Looking forward to the webinar, Andy.
Glad to hear it.
Although I assume I'm the expert.
Well, let's hope so. It's definitely not me.
We'll find out.
Okay, welcome everyone. Good evening. And this webinar, we're going to be, as Chris was saying, asking the expert on diagnostic ultrasound. So both Chris and I were always inundated with questions around diagnostic ultrasound. So we thought it'd be a really good format to put these to Chris and hopefully share his expertise and experience in this area. So the format will be is that all the questions that you've submitted, which is great, so thank you very much for doing that, I will pose them to Chris and we will work our way through those. So we've got about 25 to go through. If anything does come up in the while we're talking, then please add them in the Q&A section and we will do our very best to get them in within the hour. So I don't want to waste any time. So our expert is Chris Myers, who is Director and founder of the Sports Medicine Ultrasound Group. Extensive experience in this area, so I'm really looking forward to putting these questions to him and sharing his experience. So Chris, thank you for joining us.
Pleasure, thank you for asking me.
No problem. Okay, first question. I'm a prescriber and currently do landmark guided injections. What are your recommendations for training in guided injections?
Yep, so this was me at one point. So I was a prescriber and I was doing landmark injections. I only did landmark injections for a few months. And then I started to learn diagnostic ultrasound. So before you can even think about doing guided injections, you need to get a basic level of skill at musculoskeletal ultrasound. So actually the next stage is to concentrate on trying to learn the probe skills and start to understand what you're looking at from the structures point of view. So the first stage, if you're at that level, is to then improve your diagnostic ultrasound scans. Then as you're already doing landmark guided injections, what I'm assuming is that you have therefore done obviously a university module or a university accredited course in landmark guided injections. So you're going to have the skills of knowing what steroid to use when, how much to use, etc. So actually you're also going to know side effects, how to get consent, all of that sort of thing. So then the bit you then need is to put your ultrasound skills together with your landmark guided injection skills to carry out ultrasound guided injections. Now this depends on whether you work in the NHS or depends whether you work privately. So if you work in the NHS that I used to, we had a local guideline, and this is all dictated to by what your local policy says. Now, if you don't have a local policy, that's where you need to start. So for example, where I was working, we developed our ultrasound skills, and then we went off and we did some cadaveric ultrasound guided injection courses, like I run with SMUG. We do a 2-day guided injection course. And then from that, we had to do supervised injections to show that we could do it under ultrasound guidance. So that's one option. The second option is to do a postgraduate certificate in ultrasound guided injections. I run one at the University of East London with Pete Restaghini, and that is a postgraduate certificate, university accredited course on ultrasound guided injections. Within that, we actually cover all the stuff as well that's in an unguided course. So for some people, they may not want to do that again, but if they're not even doing landmark guided injections, then actually that course covers both the ultrasound guided stuff and the stuff that would be covered in a traditional landmark or unguided injection course. It's never a straightforward answer, Andy, as you know.
No, that's great. Okay, what is the best way to progress with an ultrasound scanning in private practice with limited mentoring opportunities? That's definitely one which we're asked all the time.
Yeah. So I think we've got to remember where ultrasound scanning came from. Ultrasound scanning came from a hospital-based environment where sonographers and radiologists would scan all day long and they would see a variety of different MSK issues or gynae issues. But from an MSK point of view, they would have a supervisor on site every day that they can scan with to get their supervised scans and get their mentoring. What's happened in the last 10 years is it started to go away. Well, it's not started to go away, but clinicians like physios, osteos, sports doctors have taken that thing of ultrasound and put it into the more clinical environment, into private practice, for example. So the question is, how do you get the mentoring that I've just explained, how they did it in a hospital? It's actually very, very difficult. And for some people, I would suggest impossible, and it's not worth them embarking on it. Because this is something that you can learn to a certain extent on your own, but you have to have some process of or supervision or mentoring. So one of the biggest barriers to learning ultrasound is getting a mentor or getting a some sort of supervision. So there are a few options out there. The best option is to have a friendly radiologist or sonographer who will allow you to scan their patients. I see lots of people that go, yeah, I've been watching radiologists and sonographers for years, and that really doesn't get you anywhere. It is useful, but this is not about observing other people scanning. This is about you scanning with somebody over your shoulder supervising your practice. What I did, so I run SMUG with a guy called Rob Louse, and a guy called John Leddy also does some teaching. I worked in an environment in the NHS there where there were 3 or 4 of us that were learning. So we privately brought in that person's time and we did a list of patients. So you can buy someone's time in to do it. The problem is with learning ultrasound, it is labor intensive from a supervision point of view. You have to be there to do it. The other option is we do something called a SMUG mentorship program, which is very popular. We had 28 people apply this year for 12 places. And the reason it's so popular is because there's such a lack of supervision pathways in MSK ultrasound. The problem is, from our mentorship point of view, is we can only take 12 because it is so labor intensive. You have to have the right amount of machines and you have to have the right amount of supervisors. And just as important, you've got to be able to get the patients in. So that's, again, it takes an awful lot of organization to do it. Those are really the main ways of doing it. So it's a bit of luck of the draw, really, as to whether you've got good contacts in these regions, but there are very few ways of getting mentoring opportunities. And that is one of the biggest barriers. And that's not it's actually very hard to get a solution to that, Andy. It's very hard.
I guess as more people start to practice and the people that have been going for a while, it'll develop. Mm. What depth of tissue do you start and finish looking at?
I'm not sure exactly what that question means, but yeah, I'm not really sure. So basically, on an ultrasound machine, the first 2 centimeters on most machines, you can see beautifully, excellent spatial resolution with a high linear frequency. A linear probe with high frequency. And then you can see deep structures. So the lateral hip, the proximal hamstring, that will go to around 6 centimeters, but obviously you are limited by depth. So when you go to a deeper region, you drop your frequency, which gives you a better image further down in the tissues. But one of the limitations of ultrasound is depth. And therefore you just need to bear that in mind. But most things in MSK that walk into my clinic, unless they're really muscular or really fat, are around that 0 to 4 centimeters where you can get a good picture.
I guess that's probe dependent as well in terms of what you use for that.
Yeah, and that's a good question. I get that question a lot, Andy, and I'm sure you do with selling your machines, is how many probes do I need? You've got your hockey stick probe, which is really good for your superficial structures, your hand and feet. Then you've got your sort of linear probe, which generally goes up to about 12 to 14 megahertz. And then you've got your curvy linear probe, which has a lower frequency. In my clinic, I'm lucky enough to have one machine where I've got all 3. But then on all my other machines in the clinic, I just have the one, which is like the one you've got in the image here, which is the 4 to 12 megahertz on your alpinian, which, to be honest, because it's got quite a small footprint, you can use that for pretty much everything that walks into a clinic.
Okay, thank you. Is it possible to grade any ligament injury by ultrasound imaging?
Well, it's an easy one. Yes. So let's take it a bit further than that. So the beauty of ultrasound, or one of the benefits of ultrasound, is it is pretty much the only imaging technique, certainly the only imaging technique that you can do in a private practice or in a very outpatient type setting, is that you can use the dynamic aspect of ultrasound. So keeping it simple, the role of a ligament is to prevent too much movement between two bones. So when you do an ultrasound scan, you can assess how much of the fibres are injured. Say, for example, the ATFL, is it a grade 1 tear where you may have some disruption, grade 2 where it's going to be a bigger disruption, then you've got grade 3 where it's actually a full tear. And that's very interesting. But what I want to know is, if that ligament is torn, is it still able to do the job of limiting the bones moving apart? Because if there is excessive laxity when you do a dynamic test, so for example, with the ATFL, you use plantar flexion to assess the ligament dynamically. For the calcaneal fibula, you'll do calcaneal or subtalar joint inversion. So you can actually see the ligament opening up or at least stretching during the maneuver, and then you can see how much the bones open up. And then you're also combining that with the feel. So are you getting to an end feel of the ligament? Because you can have a really bad tear on a ligament, but what I want to know is there laxity of that joint? Because if there is laxity, then that can cause more of a problem long term. So yes is the answer. Yes,
yeah. How many scans per week would you recommend as a starting point? I guess that's
good question. Yeah, so we've just recruited for our mentorship program, and one of the things that we ask is how many scans are you doing a week? Because I would, and this is made up, but from experience, I think I'm in a position to say this. I would say that you need to be doing around 10 to 20 scans a week as an absolute minimum, which might work out that you've got access to a machine 2 days a week. When you're learning, though, you also need more access to the machine. So I'll give you an example. With the mentorship guys, some of them may have access to a machine, say 2 days a week or 3 days, maybe 2 days a week. I know one guy who's got access 2 days a week, but we've basically said you need to buy another machine for yourself, because particularly at the beginning, you need to be scanning yourself. You need to be practicing on your family members. You need to be practicing on whatever you can. And therefore, this is where sometimes these handheld machines, which are slightly cheaper, can come in, because actually you can take that home and you can practice, and you can have it at home to practice with. So some of the guys that we've allowed on the mentorship who are only got, say, 40-50% access to a machine, we've encouraged them to buy a machine themselves to ensure that they've got access most days, at the weekends and that sort of thing. Because this is essentially a motor skill. And I always use this analogy, and apologies for people that might have heard this before, but this is a motor skill. This is a probe skill. This is hand-eye coordination. This is repetition, etc., etc. It's a whole new way of thinking. So if you were going to play the guitar and you had access to a guitar once a week, it's going to take you an awful long time, and you're not going to get very good. But if you've got access to that guitar when you go home and et cetera, and you've got access, say, 4 to 6 days a week if you need it, then you're going to get that ability to develop the motor skill, or develop the motor skill of scanning, and therefore you've got more chance of getting better at it. And remember, the mentorship, for example, is about 8 months long. So you don't have long to get to a basic level. And this is really important, is when we're talking about competency and training pathways, this is to get you to what we would consider to be a basic level of competency. This doesn't make you proficient at scanning. I've been doing it 12 years. I'm still learning every day with it. So it takes a long time, but you've got to get to that level of competency, because you need to be insured to scan. And without being able to prove your competency through your 200, 250 scans, then you are extremely exposed to not being covered from an insurance point of view. And just a quick note on insurance, Andy. I get people that send emails and phone calls and that, and they're like, am I insured to scan if I do your course? And I think, you know, any experienced clinician will know that if you, or anybody, if you ring up your insurance company, you can say, oh, I'm going to start using diagnostic ultrasound. And they go, yeah, I'll stick it on your insurance policy. That is not being covered to scan. That's only if you can then prove your competency. Does that make sense?
Yeah, no, it does.
So it doesn't matter if it's on your insurance policy. If something goes wrong, they're going to go, great, so you did an ultrasound scan. So show me why you should be doing ultrasound scans. Show me your competency. And if you don't have any learning pathway, you don't have lots and lots and lots of written up scans, then you are in a very, very vulnerable position. So if you're going to do ultrasound, you've got to get really good. If you feel you're flapping around with an ultrasound machine and really not sure what you're doing, then you're in a very vulnerable position, because as soon as you put an ultrasound scan onto somebody, you have massively changed the expectations of that patient. You know, in say, for example, you do an assessment of a shoulder, it is accepted that you're not going to necessarily pick up a full thickness tear clinically. We know that the tests we use cannot do that. If you start putting an ultrasound machine on something, the expectation is that you get that diagnosis right. So it does. You have to be able to prove your competency. You have to hang your hat on your skill level, and you have to be aware that it is putting you into a different category from a medical legal point of view, because imaging does have certainly with imaging, there is more things to consider from that point of view.
Well, that links into the previous question about the competency and mentorship and making sure that you're practicing a lot, I guess.
Yeah, so I would say, and people ask me this, you need to be scanning in clinic probably 10 to 20 patients a week that you write up. That is the other thing. You must make sure you're writing stuff up. Whether you put it, where you put that report is up to you. You know, it might just be for your own knowledge at the beginning, but it's important that you do it, because one of the skills of ultrasound is to be able to write a report, because one of the skills of being a good medical practitioner is to be able to communicate your findings correctly to the appropriate members of the MDT. And the other thing is you need good access to a machine, and it will probably take you around a year to get to a basic level if you're scanning 10 to 20 a week and you've got access to a machine outside it. And there's no quick way of speeding that process up. Some people get it quicker than others, just like playing the guitar. Some people just pick up a guitar, they've got a good ear for it, and they just crack on, and within 6 months they can play whatever. And it's the same with ultrasound. It's a motor skill. People will pick up the skill differently.
Okay, thank you. So if an ultrasound machine has only Colour Doppler, can I still use it to look for hyperaemia? Yeah.
So the quick answer is yes, you can. On a good machine, actually, the sensitivity of colour and power Doppler is not always that different. Colour Doppler comes up red and blue, so it shows you direction of flow for an artery, for a vein. Power Doppler is not specific to direction, but in theory, power Doppler picks up the small vessels. But on a good machine, I don't think it makes much difference. So I'll give you some examples. I've got a GE Logic. It's got an excellent power Doppler. It's got an excellent Colour Doppler. Andy, the Alpinion, your machine, excellent power Doppler, excellent Colour Doppler. I've also got some older Sonocytes, rubbish, like an M Turbo is what I'm talking about. Sonocyte M Turbo, which I think is an excellent machine, and it's very old now, but I still like it. It's not as good as the other two, but it's still a good machine. The power Doppler is not very good though, so you just have to be aware of that when you're scanning. So if I'm looking at Achilles, like I saw one this morning on the M Turbo, I knew the power Doppler hardly showed anything, but I knew if I'd have done it on the GE or the Alpinion, it would have been better. So you've got to know your machine. So it's actually quite machine dependent, and it's also operator dependent. There is a skill to be able to see a lot of hyperaemia around a tendon. I'll give you an example. So if you look for hyperaemia at golfer's elbow, okay, if you have the arm stretched and you go into wrist extension, so you're stretching the flexors, you won't get any power Doppler in it. If you unload it and pronate it, hang on, which way would it be? Unload it and supinate it, so everything's floppy, you get lots of power Doppler. So it's very important, the patient position, and you should use something called standoff. Standoff is where you know there's no pressure on the machine, so you can see the gel in the image, and therefore you'll be able to see power Doppler. So there's lots of points around that. But to answer the question, on a good machine, yes.
Would you use diagnostic ultrasound as a method of evaluation when using shockwave therapy?
It's a good question. So I've got a focused shockwave. I've got a radial shockwave. Nobody in my clinic would ever have shockwave therapy without previous imaging. I absolutely disagree with shockwave therapy if something hasn't been imaged. Now, you can argue with that, but that's how I like to do it. And I think that's the right way of doing it. Ultrasound is very useful sometimes at monitoring muscle injuries, but across the board, ultrasound is not very useful for monitoring tendon injuries, joint injuries. So although you can have a look like 2 or 3 weeks down the line, I would suggest that you quite often, or for every time the scan looks better, the scan actually looks no different, and it's not related to whether or not their pain is better. A good example is calcification in the supraspinatus. I use focus shockwave on calcification, and I've only had my focus for about 4 months, but I'm getting to the point now where I'm re-scanning the calcifications to see if they've changed. And there is very little correlation between whether the calcification has gone, changed shape, got smaller, and whether or not their pain has changed. So I think we have to be very cautious about monitoring any injury using any imaging modality. I could talk about that one all night, but that's sort of the main point.
We'll come back to that one. That might be a whole other webinar for that one. So in terms of integration of diagnostic ultrasound into private clinics, what is the best clinical reasoning for when to scan?
Yeah, that's a good question. So as somebody that scans any peripheral joint, any peripheral joint, I'd say 80% of the time I see a peripheral joint, I'll do an ultrasound scan. Now for me, I've got an ultrasound in my room, and the patient doesn't pay any more money for the ultrasound scan, whether they see me or if they see me and I do a scan, it's the same amount as money as if they see me if I don't do a scan. So the decision making over the scan is totally down to me, and it takes the financial side out of it. I've recently done a blog, Andy, which I think you've read, on return on investment, and I talk about that in a bit more detail. And I'm really adamant that I'm doing it the right way, although I get the arguments the other way. So this is the way ultrasound fits for me, and this is how I think it will answer Lewis's question. If a shoulder walks in, they walk in, already you're coming up with 6 to 8 differential diagnoses because of their age, because of their history. The role of ultrasound is to then prove or disprove any of those 4 to 6 hypotheses. Therefore, so if I think maybe this is a rotator cuff tear, you cannot diagnose a rotator cuff tear accurately, consistently, without doing some imaging. So if my clinical question is there a rotator cuff tear, I need to do an ultrasound scan. If I think this is an adhesive capsulitis, then adhesive capsulitis is a clinical diagnosis, and I don't necessarily need to do an ultrasound scan. If it's an AC joint problem, it's a clinical diagnosis. I don't necessarily do an ultrasound scan. Now, quite often I will, but you have to understand what is a clinical diagnosis and what do you need imaging for? And then you can answer the question, what do you scan and what don't you scan? Give you another example. An Achilles enthesopathy walks in, so insertional Achilles. If you get an insertional Achilles, as a physio that doesn't scan, you poke it and you go, that's an insertional Achilles. That's it. That's all you can say. You can't say if there's calcification. You can't say if there's a Haglund's. You can't say if there's a retrocalcaneal bursitis. You can't say if there's a paratenon problem. You can't say if there's a plantaris problem. You can't say if there's an insertional tear. You can't say if there's a tendinopathy. So if I want to know that, which I do, then I need to do an ultrasound scan. Maybe that answers it. But it takes away a lot of the guesswork. And the other thing is, all I'm doing with an ultrasound scan, I'm not doing anything clever. I'm just gaining more information than somebody that doesn't have an ultrasound scan. And obviously patients like that. They like the fact that you're looking inside the body. It takes away the guesswork. One of the reasons I love ultrasound, and I was losing or maybe getting slightly disheartened with physio, is because of the amount of guesswork. And when I started using ultrasound, I really enjoyed that I could be very confident about my diagnosis. And that reflects to your patient without a doubt. At face value to a patient, if you're looking inside something, then you are taking away some of that guesswork. So all it is an information gathering tool to allow you to make an informed decision about your treatment.
And to follow up on that, have you found that the patient engagement has improved in your time of using this before you used it?
Yeah, I think there's many factors involved in patient engagement. Obviously, communication, just the whole process of how you assess somebody, the environment you're in. There's so many factors that influence that. But yeah, without a doubt, I think it has, by adding the ultrasound in. I'm inundated with patients. And part of that is because I'm absolutely confident it's because patients want to know what's going on. They don't just all want to try something and see if it gets better. I think if you can start with a good diagnosis, in fact, not a good diagnosis, a very specific tissue diagnosis, I think you have got more chance of getting that patient better and therefore that patient engaging. And I do believe exercise compliance and compliance to treatment is improved. At no point am I saying you can't get somebody better without an ultrasound scan. Of course you can. But for me, I want to start with that specific diagnosis. And the other thing is, people say, well, you're over imaging, you're doing that. Well, I totally understand that. And when it comes to low back pain and MRI, I understand that MRI cannot, always be a positive thing to have done, and it can actually have negative outcomes as a result of it. But what's different is that the ultrasound is being done by the same clinician in the same room at the same time. So you are straight away putting the ultrasound imaging together with your clinical assessment. So you are, the whole phrase of treat the man, not the scan. We're not tempted to treat the scan because we've already done the clinical assessment and we're putting them together. And actually, as the clinician, I want to do the imaging, and then I want to actually say, I want to tell the patient what's going on in the imaging. And how I tell that patient is extremely important. And words matter, we all know that. So, for example, if somebody walks in and they're 60 years old, and they've got a partial thickness tear of their supraspinatus, that is really, really common in asymptomatic shoulders. And I'll tell them that and I can also, with ultrasound, scan the other shoulder straight away. And I might find a partial tear. I might find a full thickness tear on their asymptomatic shoulder, and they've got full range of movement on that side. So it helps to put the imaging findings into their individual and specific context. Problem is, with an MRI, they'd come back with an MRI saying partial thickness tear, and you don't know what's going on the shoulder, and therefore they may believe that this is what's causing the problem, and therefore that's what needs fixing. The reality of it probably doesn't need fixing.
Okay. So another one about education and diagnostic ultrasound. What would you say? I mean, you've covered a bit of this anyway, to become competent in this.
Yeah, so let's just go back. Competency is a basic skill level. We want to all be proficient in this, but to get competency, you need to be, it probably takes about a year scanning 10 to 20 patients a week, but also having access to being able to scan friends, family, etc., etc. I don't think I've got a blog on this, obviously, on my website as well, but it's not about the level of education. It's about being able to prove your competency. So you don't have to do a postgraduate certificate to prove your competency in musculoskeletal ultrasound. And I would go to as far as saying, I've seen lots of people postgraduate MSK education or in MSK ultrasound, and they've not been very good at scanning. So it doesn't guarantee standards. And therefore, although a PG cert should be what you should ideally do, for me, it's more about being able to prove your competency. So that looks like 250 logged scans, of which 100 would be supervised, 150 unsupervised, something like that.
Again, we've talked on Doppler.
Yeah. I mean, one thing, well, obviously where Doppler made its name is in rheumatology. So for looking for synovitic joints, which walk in physio clinics, probably every month there'll be one synovitic joint that walks in that is actually a rheumatological problem. And you treat it as a wrist pain that's not getting better, but actually if you diagnosed from the beginning and there was hyperaemia or inflammation in the synovium, so synovitis, then you could pick that up straight away.
Okay, so ultrasound guided injections, in terms of courses and practical elements of this, how do people go about it?
Yeah, so my postgraduate certificate in ultrasound guided injections would be a very good start. In terms of getting hands-on practice within that and within our 2-day cadaveric, you have 2 days in a lab on soft embalmed cadavers, and you can practice all the different injections. We do an upper limb day and a lower limb day, and I would highly recommend that course. It's always overbooked because it is exactly giving you some hands-on practice. In terms of hands-on practice on real patients, it's very difficult, very, very difficult, unless you're in an NHS setting where, you know, you've got it all set up. But if you work in private practice, the only way of doing it would be for you to buy in the time of a tutor to come and observe you do some injections. On the PG cert, we say you have to do 35 ultrasound guided injections under supervision to get to a basic level of competency, as long as you, as well as your logbook, as well as the essays, as well as your OSCE or Viva. And also, Andy, everybody's situation is different. So that's what's interesting about ultrasound is I'm a physio, we've got sports doctors, you know, we've got orthopedic surgeons. All of these people are trying to do ultrasound guided injections. And for each one of them, it will be a slightly different learning pathway. So if people have individual situations, then I'm more than happy to talk through. I do think on our resources part of it, if you could send this out, Andy, to them after, to the resources page on our website. I get so many questions. I try and answer them in a blog because otherwise I get bored of hearing my own voice saying the same thing.
Just on that point as well, and do you think that is it ultrasound that is driving the ultrasound guided injection craze, or is it the other way around? Like, is it injections driving it, or is it the ultrasound?
Yeah, good question. I think it depends on your job. So we have people that come in to we did an introduction, a 2-day introduction course in MSK ultrasound at the weekend. And some of them were there so we had an orthopedic surgeon who wanted to do hip injections. But to do an ultrasound guided hip injection, you've got to have some sort of basic level of skill. So for him, the driver was, it's absolutely pointless in his hospital to do these fluoroscopy guided. It costs a ridiculous amount of money. Their waiting lists are going through the roof. So he's like, sod it. I can do this in my clinic room. I can use a good technique and it's going to be safe. And we know the accuracy is just as good. So that was his driver. So it really depends. I would say from somebody that's done unguided injections, I never enjoyed it. It's unguided. You know, we know the accuracy level is poor. We can obviously have an argument about whether the outcomes vary. I believe they do in some cases quite significantly. So for some people, they might be uncomfortable doing landmark guided, so they want to start doing ultrasound. But for me, this all comes back to the simple thing, which is literally the starting point of everything we do in clinic, which is to get the right diagnosis. Whether you want to do a guided injection after or not is dependent on the right diagnosis. So hopefully what's driving it is diagnostic ultrasound and getting the right diagnosis.
Yeah, makes sense. So yeah, do you scan every patient that comes to the door?
Yeah, it depends. Obviously not spinal stuff, but if I feel it's going to help with my differential diagnosis, which I'm sure it must be 80% or more, then I do. But if I was somebody that was, and this goes on to my blog that I wrote, if I charged 50 quid extra for an ultrasound scan, do I have to scan every patient to get them better? No, I don't. Do I want to? Yes. Do I want a specific diagnosis? Yes. And therefore, I think it's important. And some of these questions probably are driven from how you charge for it, which we've talked about a lot. And I don't charge for it. I'm really comfortable with that because I just want to use it as a tool to gain more information. That's it.
Okay. And yeah, you've mentioned some of the brands that you've used previously. Which machine would you?
So there's so many out there now. All I can say is a few things. Is the machines are getting better and the prices are coming down, so that's a good thing. If you buy a £30,000 machine, it's going to be much better than a £5,000 machine. So what do I mean by much better? It will probably have a better Doppler and it will give you a better image quality. Now, if you're trying to look at something like the Bursa that's 1 millimeter or 2 millimeters, you need a really good machine to make what is quite a hard job anyway as easy as possible. So the issue with that is when you first start, particularly if you're in private practice, you might not want to drop 15, 20,000 pounds on a machine, and therefore you buy a cheaper machine, but you need to be aware of the limitations of that because it's not going to give you the best image that you can. If you speak to anybody that scans a lot, all we want is the 80 grand GE E10 or the Toshiba or the Canon now. So we want the best machine we can because we know the limitations of not having a good machine. So you need to buy a good machine. And what I mean by that is 10 grand plus if that's going to be the only machine that you have in your clinic. You can buy handheld machines, and I think there is a role for handheld machines. But for me, I wouldn't want to just have a handheld machine. I would want a proper portable or cart-based machine in my clinic.
Okay, we'll send the blog out that you've written on
yeah,
that.
And the other thing is if you it's that whole thing, buy cheap, buy twice. I'm not saying that these machines at 5 grand are cheap. As I said, there is definitely a role for it. But if you think that this is going to be something you do for the next 20 years, then I would suggest that you try and get over that 10 grand sort of mark and get a good quality machine. So in 2 years, you're not looking to upgrade, which is often what happens. So you're better off just getting it in the first place. But then you've got to be sure this is for you. You've got to be sure you've got a learning pathway. You've got to be sure that you can commit to it. So you need to do your research at the beginning.
So yeah, training. How do you get started with the training? I think that ties into the previous question where we get that question all the time. What comes first?
Yeah. So I mean, put it this way: you can't learn diagnostic ultrasound without a diagnostic ultrasound. But I would say 20%, maybe a bit more. Come on our 2-day introduction course. Realize what it takes to get good. Realize that it's going to be a 20 grand investment or something like that, over the first few years in terms of training and machines, and then probably never scan again. But they've understood a bit more about ultrasound. They understand a bit more about the anatomy and what they can see with ultrasound. So they may be able to refer off a bit more for ultrasound instead of MRI, but they don't actually go on and do it. So we do a 2-day introduction course, which if you're not sure about ultrasound is probably a great way of just finding out a little bit more and paying the fee for the 2-day course instead of buying a machine and it just sitting there and getting dusty, which we know happens.
So how do you decide which type of steroid to inject per joint?
I mean, that's quite straightforward. 90% of the time, I only use one, which is depamedrone. So methotrexate. Well, actually, I occasionally use Kenalog for joints. which is a triamcinolone, but generally I'll use depomedrone. Literally 90% of the times, that's a really easy question to answer.
Okay. In terms of mentorship, how do you go about finding that? I know you've mentioned your SMUG program.
Yeah, what's that?
You mentioned the SMUG program in terms of that. I mean, I think one of the things that we've found challenging is like the regional networks of mentoring. And like, I think a good question at the moment to add on to this would be online. Like, could you do any sort of online mentorship?
I think if you've got a basic, if some of the guys that I know who are sort of like that, if you're a complete beginner, I'd struggle to do it online. You can pick up the physics, you can pick up the basics. We're going to start doing some online modules, so you know, that sort of thing. But this is, again, it's a bit like any motor skill. At some point, you've got to have some face-to-face teaching. And I go back to, we've got to remember where this started. This started in radiology clinics and hospital clinics. And to a certain extent, we're bastardizing that training program and trying to put it into more of a clinical environment. And it doesn't totally fit the way that it should, to be honest. So I think you can do a little bit online, but this, I think a good bit of this needs to be face-to-face, but it could be with peers, you know. So if there's 2 or 3 of you in a local location, when I taught, there was 3 or 4 of us in the same department, we'd spend any waking second at the clinic scanning each other and learning off each other. And that's one of the key bits of learning ultrasound. So it doesn't always have to be with your mentor or supervisor. In terms of what makes a good mentor, I would suggest it's somebody that can commit the time to help you, because most guys who would put themselves up there to mentor have the skill set, and I know this from being involved in postgraduate certificates, probably 20 to 30% of the people that, maybe even more, that apply for postgraduate certificates, by the time it comes to them starting in September, the mentor said they can't do it anymore, or they moved jobs, or they said, oh, actually, I need to mentor the sonographer, or they say I can only do it once a month. So there's lots of barriers really to mentorship.
So how would you start that process?
There is not a network of mentors in this country. So it's a very hard one, Andy. I don't have the solution other than what we set up, but we can only do 12 people, you know, two courses every 3 courses every 2 years. So you'd have to speak to your local radiologist, you'd have to the department, you'd have to speak to your local sports doctor. It is just about who you know. There's no formal way of getting a supervisor. None of the universities will help you. They might send them our way, but essentially none of the universities have a network that will mentor. So this is a barrier that you're going to come up against. Unless you're lucky, like the guys that work at my clinic, you know, where there's 3 or 4 of us that can mentor them. But then, you know, there's a win-win there, isn't there?
Send your CVs to Chris if you want a job with Chris. I'm sure they'll look at them. So I've trouble setting up colour and power Doppler. Any tips about setting that up?
So first of all, you're never going to know how to use your machines totally. And this is where the guys that sell the machines need to have good contacts with application specialists who will come around and help you do that. That is essentially what you need to do. Now, so I mean, there's many things, as I've already said, that will affect colour and power Doppler. So if somebody's late for their appointment and they've run to your appointment, you may actually get more colour or power Doppler just from that. The position of the patient is important. So whether you've got it on stretch, or what you want is a really relaxed region, so you're not compressing the small vessels. Using standoff gel, so you can see the gel in the image. And the other thing I sometimes do, if you're not sure what level to use, is I'll put the probe onto a bit of bone. I'll turn it up so you get lots of artifact. I'll turn it down so there's no blood flow within the bone, and then I'll take it to the area of tissue. So yeah, those are my top tips. So, what is all this about Doppler?
Anything you want to add to that, or are you happy?
No.
Hip ultrasound specifically.
Somebody just said, why bone and not artery? Because you could use artery. I haven't used it, so I'm assuming it's the same principle. But I think the artery, you'd have to go really, really low to not see it, because it's a big vessel, obviously. Try it, whoever said that. Yeah. How can I learn hip ultrasound? You need to go on a hip ultrasound course. So it's the same thing, isn't it? You can look on YouTube. You can use the ESSR guidelines on the hip. There's loads of good books out there. The John Jacobson book, I would direct you to. As I say, YouTube's got lots of good stuff. You could get somebody over to teach you it. You could come on one of our courses where part of it would be on the hip. But learning ultrasound often goes back to the anatomy books. But the problem with the anatomy books is they don't look like the real thing. So certainly correlating to MR and cross-section of MR is a good solution.
Okay. I mean, this is a massively generic one, but are there any, can you give me 3 things that you would say to someone from ultrasound scanning, top tips?
What, that's starting out, or?
Yeah, from a starting out perspective.
I mean, so if you go to my resources, there's a top 10 tips for getting started in musculoskeletal ultrasound. So that would be a good starting point, but access to a machine, like absolutely, without a doubt, the most important thing. Access to ideally other people that are learning, that makes it more fun. You can bounce off ideas, and essentially you need models. And, meeting up every Tuesday night to do ultrasound, that's what we used to do. I can't remember what day it was, I think it was a Monday night. We used to stay behind and just scan a joint. So we do hip one day, shoulder next day. That's actually how SMUG started. We used to do something called LUG, which was just me and a few of the other guys, which was London Ultrasound Group. And then we started to run a course. We called it MUG, Musculoskeletal Ultrasound Group. And then we realized that what we're doing had more of a sports medicine basis. And then we came up with SMUG. So 1 is access to a machine. 2 is try and find people in your local area that you can learn with. And 3 is you need to attend courses. I've been doing it a long time. I teach with Lorenzo, John Leddy, Mark Maybury, Rob Louse, obviously. We still attend courses every year. You never stop learning. And ultrasound, the imaging is getting better and better. The research is getting more and more, and what the information gives us is getting more detailed.
So, so this one before. So how do you use ultrasound and see an individual? I guess that's a specific muscle. Can you target that?
So, it's very straightforward. You can see, if you pretty much see every muscle in the leg and every muscle in the upper limb, and it's great for looking at muscle tears. It's not so great at looking at the sort of grade 1 tears, but certainly grade 2, grade 3, seeing if there's a hematoma, seeing how much of the muscle fibers have been damaged is really important and really good to see on ultrasound. But again, it's difficult. It's a skill. You've got to get lots and lots of hours of learning to be able to identify them, because it is just, it's a big mosh of grey, and you need to be able to differentiate, the different areas. And then the area that I've certainly got a lot more interest in recently is it the muscle that's involved, or is it the tendon? And I'm not talking about tendon muscle. As anybody that scans knows, that actually that tendon goes through the muscle, and often you have an intramuscular tendon. And so I'm very interested in whether the tendon gets injured or the muscle gets injured, because your healing times are different. So a gastroc tear, we want to know whether the aponeurosis is injured. If it's a calf tear, we want to know if the central tendon is injured. If it's the rec fem, we want to know if it's the indirect or the direct head or the central tendon. So, you really are looking at a different layer of anatomy, and therefore a different layer of diagnosis. And I'm not saying you need that for every patient, but there is definitely, and it's definitely a nice starting point.
And just to add on to that one, a question that we're asked a lot is, say, from a football team or sports team, how long should you leave it before you scan in the acute phase?
Yeah, so and I had this question by one of the guys at the weekend who works for a Premier League team. So if a patient walks in at half time and says, "Doc, I think I've pulled my muscle," I'd be very, very wary of doing it. In fact, I wouldn't ultrasound scan it, because it's very unlikely that that thing is already organized. What you see on ultrasound, fluid is very clearly seen on ultrasound, but it takes time for fluid and the trauma to organize itself. So I would be tempted to say 48 hours. But as that matures over the next 3 or 4 days, you often see more and more. So you have to be very, very cautious scanning acute injuries, with reference there to muscles.
So how do you sonographically assess a subtalar joint and sinus tarsi?
So a quick video. So the subtalar joint, you can look at medially. So you find the sustentaculum tali just beneath that, just proximal to the FHL. Laterally, find the CFL, and underneath that is the subtalar joint. To find the sinus tarsi, find the ATFL, and just slide forward, and you'll see a hole.
Cool. We'll come back to the video another time.
Yeah.
Meniscus.
Yeah, so you can see the peripheral margin of the meniscus, you can see the posterior horn of the meniscus, but you can only see the periphery, you can't see the deep area. So obviously MRI is better for that. I generally will look at it in with the knee semi-flexed. I'll look medially, laterally, I'll bend the knee slightly with the patient prone, and I'll look at the posterior horn just underneath semimembranosus and on the posterior capsule, which is a really interesting area to look at. And then I'll do something dynamically to see whether it protrudes, both on the joint line and posteriorly. And obviously meniscal cysts. I saw one of them yesterday. I drained a meniscal cyst, which was very satisfying, on the lateral side, and you see meniscal cysts brilliantly.
Now, this next one is definitely one that we're getting more and more questions on in terms of PACS. So do you use PACS in your clinic, and if so, how have you gone about doing that?
So no, so this is, I think I've spoken to you about this, Andy. So one of the things I like about, say, for example, the Clarius machine when you're learning is it has a really good cloud system. And I did a review on it. I think you saw it, Andy, and it's on YouTube, or it's on our links off the page. But yeah, what I really liked about it is you scan in clinic, you press save, it's gone straight to your cloud, you get home, you log into your Clarius account, and all your scans are there. And that's, for me, where all ultrasound imaging should go. So at the moment, we don't have a PACS system in clinic. We just save the images on and then save them onto hard drive. But what I would like personally, because I've started sending out images as part of my letters, is I'd love to come home and have them all here. But at the moment, I have to just put in the USB key and export it and then upload it. It's quite cumbersome. But yeah, I don't know. There's one called, so I only know the links from GE, which is Trustify or something like that. There is one, but they're all very cumbersome at the moment from what I've seen. But if anybody else knows of a nice system, the problem is that the systems don't connect to the Wi-Fi simply. You can't just connect an ultrasound machine. Well, you can, the Clarius does, but generally speaking, you can't. And the Butterfly does it. I wouldn't buy that for MSK. But the most ultrasound machines don't just connect up to Wi-Fi and then you can get onto a cloud. So it is quite cumbersome.
Yeah, we're looking into that as well. So we'll maybe.
Have you got anywhere with it?
Still, yeah, same challenges as you. So I think, like you say, all the systems are very clunky at the moment. So that's a big one for us in Q1 of next year.
Yeah.
So yeah, any tips around the Adductor Magnus posterior?
So I mean, I don't know who's asking. I'd have to know exactly what they mean. You could see the Adductor Magnus very clearly on ultrasound. You can see its attachment onto the ischial tuberosity as well as the ramus, ischial ramus. But yeah, you can see it. But I don't have any specific tips. It's not an injury I've seen much of. The only time I look at Adductor Magnus, or I have more to say on it, is it is like the fourth hamstring. So there is the ischial tuberosity attachment of Adductor Magnus, and you can see that medial on the ischial. It's the most medial tendon on the ischial tuberosity next to the conjoint tendon. Yeah, conjoint.
Okay. So what would you recommend as the best portable ultrasound device? So again, we've covered that one. So what we'll do is we'll send out the several links that we've already discussed on that, Chris.
Yeah.
Your resource page. So I believe this is the final question we're going on to. So yeah, I'll let you.
I see a lot of bursitis. So as a percentage, I see loads of frozen shoulder. So maybe 40%. So if you think about the shoulder, you've got the AC joint, you've got an intra-articular for OA, or mainly what we do it for is frozen shoulder. You've got the long head of biceps, and you've got the bursa. So I'd say AC joint is 10 to 20%, versus maybe 30 to 40, frozen shoulder 30 to 40, and whatever for long head. We don't do many long head, so 30 to 40%.
Okay, great. Well, that has brought us to the end of this evening. So, Chris, thank you very much for your time. So, just to summarise on that, so Chris, what we'll do is we'll send the resources that we've talked about in that discussion there, because I think there was a lot that can really help the people that have asked those questions. In terms of upcoming events for us, we've got a Shockwave therapy, which is the system that Chris was talking about from a focus perspective with the Alpinian Diagnostic Ultrasound. So we've got that tomorrow. So please join us if that's specifically the people that are looking at implementing this technology into your practice. So we'd love to be able to help you with that. And then next week is with a friend of mine who's director of outpatients at Johns Hopkins, so one of the biggest and best respected hospitals in the States. He's going to be talking about managing myofascial pain. Again, that's with the piezo wave system, Shockwave, which is very, very popular at the moment. So any of those, please let us know if you'd like to join. We'll be sending out the links for that afterwards. But other than that, Chris, as usual, thank you very much for your time. And
can I say one thing?
Yeah, please.
You can't see trigger points on ultrasound.
Right, okay.
Question I get a lot of the time.
Yeah, well, please join that. And I think you and Kenneth have a good discussion on some of those things, actually. But yeah, thank you all very much for joining, and we'll be announcing our upcoming webinars again. Hopefully we'll be booking some more in with Chris, and we'll see you soon. Thank you, Chris.
Thank you.